Thank you so much for that warm introduction. Good morning, everyone. I know I stand between you and lunch, those virtually lunch breaks. So I'm well aware. It's an honor to be here. Thank you, Robert, for the invitation to come and speak about something near and dear to my heart, suicide prevention. I've been a mental health worker for many, many years, and we can never hear this enough and be prepared enough whenever we need to have the information. So the topic today is Suicide Prevention 101, Mental Health Update and Toolkit for 2023. Try. I don't have any disclosures. So our objectives: to recognize the global impact of suicide. Some has been talked about earlier today, but I'll expound upon that. To identify the psychiatric diagnoses most commonly associated with suicide. To recognize comorbid conditions, individuals and groups at highest risk for suicide. To recognize warning signs, risk factors, and protective factors. And to learn how to perform effective suicide risk assessments, learn what to say, what not to say, with some of the questions about practical things. And to review intervention strategies to help save lives. So we are here today because suicide is a major public health issue. We are in crisis. Globally, approximately 800,000 people in the world die by suicide each year, and that is 1 every 40 seconds. And that's 2021 data. Approximately 48,000 people died in the US by suicide in 2021, as was mentioned earlier. We want to move past the stigma, which causes far too many people to suffer in silence and even worse, take their lives. Suicide is the second leading cause of death worldwide for those ages 15 to 24. It's the 11th leading cause of death in the US in general, and the third leading cause of death in the US for our ages 15 to 24. Now, what has been said is nearly 90% of those who die by suicide, when you look, have a diagnosable mental illness or substance use issue at the time of their demise. I know we're going for zero suicide, but if you really look at the data, many times we have some preventable reasons for suicide, and that's what we're looking at getting to right now, treatable reasons. The highest rates for 100,000 remain for white males, which is 26%, followed by American Indian, Alaska Native males, 25%, and now an increase in Black males, 14% of suicides. In the US, 1 male dies by suicide every 13.7 minutes. There are 3.9 male deaths for each female death, but there are 3 female attempts for each male death. So females attempt more frequently than males. And if we look at our population, ages 25 to 44 made up about 26% of the population in 2021, but they made up about 35% of the suicides. And older adults, we have a neuropsych unit here, made up 17% of the 2021 population and about 13.5% of suicides. So what we really want to do is identify those at risk. And we're focusing on mental health disorders because they cause disturbances in thinking, emotional regulation, and behaviors. And we believe that much of this can be prevented by adequate treatment, and treatment exists. Okay, so some of the psychiatric diagnoses with the highest risk of suicide: major depressive disorder, bipolar disorder, schizophrenia, borderline personality disorder, and substance use disorders. According to the Centers for Disease Control and Prevention, US suicide rates have increased some 30% since 1999. Actually, anorexia is the psychiatric diagnosis with the highest mortality rate, some 5 times that of other psychiatric illnesses. It's higher than schizophrenia, which has a 2.8% higher risk of death in males and 2.5 in females. So Suicide and anorexia is thought to be roughly 20% of those who die. Something to take note of. Smaller numbers are very, very impactful in terms of risk. Depression is thought to be present in 45 to 50% of those who die by suicide. And in bipolar disorder, the increased risk of death is 2 times higher in males and in females. So men account for about 75% of suicides, though twice as many women will attempt suicide. And one of the highest proportions of suicide occur in actually US physicians. They have some twice the number of suicide deaths compared to the general public. And we don't talk about that. So, major depressive disorder, these are the symptoms, we're all familiar, but persistent feelings of sadness, guilt, worthlessness, hopelessness, helplessness, loss of interest in things that used to bring pleasure, decreased energy or fatigue, problems with concentration, remembering, making decisions, problems with sleep, appetite, and then thoughts of death or suicide. So there's no single cause for suicide. People ask, what is it? It most often occurs when stressors and health issues converge to create an experience of pain. Stan talked about the pain versus the hope. So it's a pain response. I often speak about suicidal thought as like having a fever. We all get a fever and there's something wrong. We don't know what is wrong, but it alerts us to something being not right. So we have to follow that. And if a child gets a fever, we really are invested. So if somebody's talking about suicide, it really is an alert that something really is painful and not right, and we need to investigate further. Depression is the most common condition associated with suicide. It's often undiagnosed or undertreated. Especially concerning are those feelings of profound sadness when people talk about feeling that they're a burden, the heaviness, the fog, the weight of depression. Those should alert you to a serious depression. Hospital visits for urgent care mental health care increased in young adults and teens in the second year of COVID-19, often because of some of this heaviness and the thoughts of depression that they were having. These are all NIMH statistics or AFSP or APA statistics. Lifetime prevalence of depression is about 20 to 25% in those 18 and over. So 25 million Americans suffer from depression, but not everyone has depression, has suicidal ideation. We really need to focus on doing some identification of who are these people most at risk, and that's why we're here. The good news is the depression is treatable. 80 to 90% of people who seek treatment respond. However, only half of Americans who have depression receive the treatment they need, and that's a NAMI statistic. So treatment includes antidepressants, cognitive behavioral therapy, supportive psychotherapy, group therapy, also ENT, ECT, Dr. Doctor talked about, and transmagnetic craniomagnetic stimulation, as he spoke about, and some of the novel treatments with ketamine and psychedelics. Okay, bipolar disorder. So major depression we spoke about. Bipolar disorder includes hypomania or mania. Mania consists of increased self-esteem, grandiosity, decreased need for sleep, having somebody who's talkative or pressured speech we talk about, flight of ideas, feeling very distracted, impulsive, having excessive spending, somebody who really looks kind of plugged in. And it really has to do with the duration. If it lasts more than a week or it involves hospitalization, it's a mania, it's a manic episode. If it's lasting 4 days, but not a week, we call it a hypomania. As many as 15% of people who meet criteria for bipolar disorder will die by suicide, and half will attempt at some point in their lives. And 80% who will contemplate doing so. So we really have to really do great risk assessments on paper when they're not euthymic, they're either manic, hypomanic, or depressed, because they're at greater risk for suicidal thoughts. Okay, schizophrenia. is a psychotic disorder, including delusions, hallucinations, disorganized speech, disorganized behavior or catatonic behavior when people are mute or don't move, and negative symptoms, really decreased expressions, a disconnect in the mind. Delusions are fixed beliefs that are not amenable to change in light of conflicting evidence. They are false beliefs. Examples are persecutory, paranoid. Hallucinations, on the other hand, are perception-like experiences that occur without external stimuli. They're vivid and clear, but not occurring in another's reality. In other words, the event occurs only in this person's mind. No one else witnesses it. But you're able to ask, especially with voices, whether they're male, female, group, loud, commanding, and they can point to where the voices are coming in the room. It's a very interesting phenomenon. However, 1 in 10 suicide deaths is linked with schizophrenia. Despite accounting for just 1% of the population, people with schizophrenia and spectrum disorders, psychotic disorders, represent nearly 12% of people who die by suicide. So you have to ask about the quality of the voices. Are they commanding? Are you feeling like you can reality test? I know they're not my own voice. Or they feel like they have control over you. Very important to ask. Borderline personality disorder. Diagnosed after age 18, it's a pattern of instability in interpersonal relationships, self-image, affect, marked impulsivity. People have difficulty controlling their anger and rage. They have very unstable and intense interpersonal reactions because they're very reactive. You almost talk about walking on eggshells because folks really have a misinterpretation sometimes of the stimuli that they get. They avoid frantic efforts to feel abandoned, and this also can cause impulsivity. And there are recurrent suicidal behaviors and gestures as a part of this disorder. The treatment of choices, psychotherapy, dialectical behavioral psychotherapy, focusing on coping skills to manage emotions, to relieve stress, and to really help people negotiate and improve interpersonal relationships. 75% of borderline personality disorder patients will make at least one attempt in the lifetime. And people with bipolar, borderline personality disorder are more likely to have suicidal ideations than any other psychiatric disorder. So it's very, very high. The suicidality, the thoughts of suicide are very high. And it has to really do with the negative emotional expression that they feel, the pain that they feel because of the thoughts. And it's also very comorbid with bipolar disorder and depression. So then we move to substance use disorders. The essential feature of a substance use disorder is a brain disease. And patients, despite negative consequence, are drawn to crave and get into a craving and rewarding system driven by dopamine, an limbic system. And there's treatment for substance use disorders. We talk about it, sometimes they disinhibit, and the hallmark of substance use is really impaired judgment while impaired. So that also leads to people with higher use as suicidal thoughts. These are the substances that we often look for. And most noteworthy right now, drug overdoses are very, very, it's another epidemic we have. We lost about 106,000 US Americans to overdose in 2021. That was up 14% from 2020. Analysts point to 2 major reasons for this increase. A growing number of Americans are using opioids, and drugs are becoming more deadly. The second factor is the illicit manufacture of fentanyl. And 70% of those who died were male, and 26% were 35 to 44 years old. And the largest percentage had some fentanyl in the drug when they died. We do have treatment for substance use disorder. We have medication-assisted treatment. For opioid use disorder, we have buprenorphine, we have methadone maintenance. And for alcohol use disorders, we have naltrexone, acamprosate, and disulfiram. They're all FDA-approved treatments for alcohol use disorder. It's treatable, usually within the context of a program. We also have AA. The social recovery model is very, very effective for people. So some comorbid conditions that elevate suicide risk in addition to those primary psychiatric disorders, anxiety disorders, and early childhood trauma, which was touched upon before. Also precipitating factors are the end of a relationship or divorce, death of a loved one, legal issues, and serious financial issues. So anxiety disorders, basically we're talking about excessive worry that you cannot control, fear of the future, doom, gloom, dread, and inability to control worry. Also, you can have physical symptoms like fatigue and headaches and muscle tension, insomnia, irritability, nausea. Generalized anxiety disorder and phobias affect more than 40 million Americans annually. So it's the most common psychiatric disorders and anxiety disorder. But comorbid with depression, bipolar depression, substance use really increase the risk of suicide. So we had a study that was done, the ACE study. I'm sure many of you are familiar with it. It was done at Kaiser Permanente San Diego, done in conjunction with the CDC. Back in 1995 and 97, they did a questionnaire really asking their members about their experiences in childhood. And what we found was that about 1 in 7 or 1 in 8 children experienced child abuse and neglect in the last year. More than 2/3 of people who reported at least one adverse childhood experience. The childhood experiences they were looking at were physical abuse, sexual abuse, emotional abuse, physical or emotional neglect, exposure to domestic violence, household substance use, household mental illness, parental separation or divorce, and then having an incarcerated household. So adverse childhood events were pretty common, with 40% of people reporting 2 or more experiences from childhood. And there's a dose-response relationship, meaning the more ACE that you have, the higher you score later in life with some physical and mental issues. So one of the high-risk populations for suicide, of course, is LGBTQ youth. When compared to heterosexual males and females, gay men are 6 times more likely, and lesbians are 2 times more likely to attempt suicide. And there are even higher rates in the transgender population. And as they looked at the responses from people, the youth did not kill themselves because they were gay, but more because of the homophobia, discrimination, stigma, depression, anxiety that came along with society's stigma and family rejection. Another high-risk population that Robert talks about a lot are U.S. veterans. They have a significantly higher rate of suicide when compared with civilians. In 2020, there were over 6,000 veteran suicides. 16 to 17 veterans dying by suicide daily. And between 2001 and 2020, the prevalence of mental health or substance use disorders among veterans rose from 28% to nearly 42%. Suicide was the 7th leading cause of death among all U.S. veterans in 2020. So let's look at some of the risk factors for suicide. So we talked about adverse childhood experiences, also previous suicide attempts. Knowing someone who has died by suicide increases the risk of suicide, particularly a family member. Misuse and abuse of drugs and alcohol. Health and social factors, mental health disorders, as we discussed, a lack of access to care, social isolation, and serious physical, including pain syndromes, also increase risk and disability, physical disability. Environmental factors, Stan talked a lot about access to lethal means. including firearms. More than 50% of people who die by suicide die by lethal means. And then stressful events like rejection, divorce, financial crisis, and death of a loved one. So when we talk to people about how they're feeling, we think about talk, behavior, and mood, and this is from the American Foundation for Suicide Prevention, the education that they give. If a person talks about wanting to take their life, feeling hopeless, having no reason to live, feeling like a burden, talking about the pain of their emotions, feeling trapped or unbearable, it's a warning sign that it's just not a sad day. It's inconsistent and it's trending towards something concerning. The behaviors that you look for are folks who are withdrawn from activities, isolating from family and friends, people that used to return texts and phone calls who no longer do, check on them, sleeping too much or too little, just a change in behavior, giving away some prized possessions, making plans that you wouldn't feel. We have a gut sense as people. Listen to that gut. It's there for a reason. If there's a change in behavior from somebody that you know really well, we're going to talk about what to do. And then we look at moods. You know, when people are consistently down, very worried, lose interest in the things that they used to enjoy, fly off the handle and are irritable, talk about guilt, feeling shamed. They're more agitated, easier to go to anger, or have a sudden relief, and all of a sudden you look at all of their social issues and they're fine. That's concerning. We have protective factors, effective mental health care. We're really here about prevention. Everybody here can be a lifesaver if you know what to look for. So knowing what to look for, getting people effective and connected to family resources, community resources, cultural and religious resources, learning some problem solving skills. Sometimes when you're so depressed, you can't think your way out of a box. But when somebody else can open up the door and say, hey, have you thought about this? Have you thought about this? Let's give this a try. Sometimes in the depression, there isn't any room to problem solve. That's helpful with therapy. And then having contact with caregivers if people are disabled or in pain and are isolated. Just even contact with caregivers decreases the risk of suicide. So we believe that suicide is prevention. It's preventable. In many instances, we believe it's preventable because we're saying about 90% of people have an undiagnosed or undertreated mental health or a substance use disorder that we can be addressed. How to intervene. Now that you've become familiar with the statistics, the symptoms and the sign, what's next? Many of us have lost family and friends to this health issue. Who are the faces of suicide? At any given point as a mental health provider, I could switch places with anybody that I see. We all could be there. So today might be for someone here. It might be for somebody you know. It might be for some situation that's coming up. But you just have to ask the questions to see where people are. It's not a terminal illness, but it is a deadly illness if people don't see the warning signs and don't feel like there's help. If you suspect somebody's at risk, this is what we do. We look at past attempts. Have you ever thought about taking your life? You can say suicide, it doesn't put it in their mind. If you're thinking it, you say yes. But you're gonna do this in the confines of some protected time with a relationship that you feel like you have. Have you thought about what it might mean to end your life? Have you done anything to hurt yourself? And then the big question is, do you have access to a weapon? That changes the game. And Stan talked about time. Suicide is like a fever. We're not persistently having a fever. It comes and it goes. But in those moments, if you can separate someone from a lethal mean, you've saved a life. So it's nice to know if they have access to a weapon. What is your plan? What do you think will happen? It's a pain response. A lot of people feel like they're a burden, or their pain is too much to bear. What things put you at risk for ending your life? What things prevent you? What do you live for? We're talking about safety planning. It's a lot of resources, but really, what, at the end of the day, when you're not in as much pain, do you live for? What is your purpose? What is your mission? What is your meaning? It's hard when you feel so bad, but we're gonna come back to that because everybody has a meaning, a mission, and a purpose. But in pain, sometimes you can't connect to that. So you want to determine the risk level. High risk, numerous risk factors, and low protective factors. Usually, this is a hospital admission for safety and further evaluation. Potential lethal suicide attempt or a strong, persistent ideation that does not go away. Folks need to be in a safe space. Medium risk. Multiple risk factors, but a few protective factors. This is where the safety plan, that crisis plan comes in. So that they can pull that out, or you can remind them when they were feeling better, this is what you said you wanted to do. This is what you were living for. This is who we call to help you get out of this headspace, including what will precipitate the need. So if you get to this point, this is when we call. But if you're at this point, I think that we can go back to our safety plan. Let's make sure that you see your therapist or your doctor, you're taking your medications, you're doing what you do to keep yourself healthy. And then low risk factor, fewer modifiable risk factors, strong protective factors. A thought of death that's passing, but no plan, no intent. Outpatient may be the most appropriate, or an emergency crisis number, someone to talk to in that moment can be a game changer. So important questions to ask. Don't be afraid to ask the tough question. Assume you'll be the only person who'll say the yes word. What do you say? I've been concerned about you. I wanted to check in on you because you haven't been yourself lately. Have you had thoughts about suicide? Have you had thoughts about taking your life? When did you begin to feel this way? And how can I support you right now? You want to stay with them. You're not alone. I'm here for you. We can all say that. I may not understand, but I'm here to help you get through this. Helpful. You may not believe it, but the thoughts you have now can change. I want to stay with you until they change. Be sure to be present, listen, and offer hope. This is not the time to argue or rationalize or reason with someone or to fix their problems. It's really a time to make sure that they can be safe. And if they can't be safe where they are, we're going to get them to safety. So here are some of the resources. We have a National Suicide Prevention Line as of July of 2022, it's 988. In the last year, there were 5 million contacts, 1.6 million calls. There were 600,000 chats and around 300,000 texts using this. We also have the NAMI helpline, 800-950-6264, or you can text helpline to 62649. There are resources at NAMI.org, AFSP.org, and SAMHSA has a behavioral health provider and treatment website. Also, Mental Health America has a website to find help. So these are some of the references that I used. Most of this is public data now. And we'll go to questions. Thank you.
Lisa, I guess you have a few online questions.
What early detection assessments methods would the public health nurse use for helping high-risk individuals?
Absolutely. So someone who's new, you really want to get a sense for the level of distress, whether this is a new instance for them or not. If they're there with you, you want to ask them directly, are you thinking about suicide? And if you are, what have you thought about? What have you planned? What have you done? Just to get the level of risk. And if you're not getting the answers that you need to safely make an outpatient plan, then you make an inpatient plan. Because you always want to err on the side of safety. And sometimes people can't even articulate where they are. That's not a good sign. You want to keep them safe until they're able to give you some definitive answers.
Is there a statistic that shows poverty as a factor?
There likely is. There are social determinants that influence all of these mental illnesses. And if you're looking at some of the studies in our Black and Brown communities, poverty and stigma and racism all contribute to the social determinants of care that we all have. So it's additive for marginalized people.
Right, do we have any questions in the room?
Hi, my name is Isabel, and Stan spoke of like him being suicidal after he was injured. Is there follow-up after patients that, and assess their support system after they leave the hospital, to minimize the risk of suicide?
Yeah, absolutely. So in terms of, so I can speak to my medical center, Downey Medical Center. As people are admitted, we do PHQ-9s, we do assessments on mental health. And we also use the CSSR, which is the Columbia Suicide Rating Scale, usually on admission and on discharge, just to make sure that we are not missing someone who is not safe to go home. And part of that discharge planning would be to connect those people inpatient to outpatient psychiatric or substance use outpatient resources to follow up, if that has been a reason for admission or something that is discussed during admission. But we do some screening at the time of admission, and even at the time of primary care visits now, specialty care visits, we're asking people routinely, are you safe? Are you safe in the home? Is there something we need to know? And that is flagged and addressed in primary care now.
Behind you, Karima, there's one behind you.
Good afternoon, once again. My name is James Mumma with VPAN, Veterans for Access Network. As far as a veteran, I'm a Marine Corps veteran. We have a Navy veteran here, and we provide services for those that are in these particular situations. We're trained in suicidal ideation, 5150s. So what I want to try to do is give some information. If you know of a veteran that is in crisis, 1-800-854-7771, option 3. Okay, what that does, that's a warm line for anybody that is having a moment, that is in desperate need of support from the Mental Health Society. So just wanted to we're the first table that you come to right out here. If you need the flyer, we have it. It's very important, and I applaud you. You are a godsend in what you do as far as suicidal ideation. This is very important. We have so many veterans. I actually think the number is a little bit higher as far as suicidal ideation is concerned, but America is not ready for that yet. They're not ready for it because it's much higher. I am lived experience from that, okay? Having a veteran, and we also work with LA Sheriff's Department. We call what is called as a VMET team, Veterans Mental Evaluation Team. They could care less if you stole something in front of them. What they want to do is provide that assistance to veterans that are thinking about suicide, whatever that situation might be. We're here to provide services throughout the United States to families. We have a wraparound service that also provides mental health support for the entire family. So just wanted to kind of put that out there. As more information that is out there, the better off we are equipped to be able to handle these particular situations. Thank you.
We do
We do have lots of resource providers at our table, so we'll take an opportunity during lunch to visit all of those. I think we have another question online.
Can I have your name, sir, again? What's his name?
My name is James Muma. I'm a supervisor for VPN, Veterans for Access Net.
Thank you, James, and for your call. Thank you for your service. And this is absolutely needed. Please see him outside.
Hello, Dr. Walton. Thank you for bringing your experience and compassion to this topic. Regarding substance abuse disorders and deaths of despair, how would you describe the distinction between depression and despair, if there is one?
That's an interesting question. So depression is more of a clinical, diagnosis where I have 11 symptoms, and if you meet criteria for 5 out of 11, you have depression. Despair is more of it's more of a sort of a mind state that can be transient based upon situation. I think we can have moments of despair and not be depressed. In those moments of despair, we can have all sorts of thoughts. But when we talk about clinical depression, that actually has a treatment and algorithm. It's a little bit more clinical. So that would be the distinction.
Please identify key steps of safety planning with a child and parent post-psychiatric hospitalization.
That's an excellent question. So that should be done prior to the child leaving. I'm an adult psychiatrist, but I have treated children in residency and more on an on-call capacity. But you want to make sure that the child is able to speak freely. And then you bring in the parent as well, because some things won't also be shared. So you want to respect that, and whatever the child does share, if they're a minor, you then have to let them know you're going to share with them. And it's also for safety, but you really want to give the child the opportunity to express themselves and their experience in the inpatient setting, and then also let them know that part of having them return home is to let everybody open up transparency. Because with transparency and open communication, I believe there's so much more healing. And we don't want this to be stigmatized. You were treated like you would be treated for anything else. Asthma, exacerbation, these are the inhalers that you use. This is the symptoms that you have to use it. Your parents will help you with this. It should be nothing different than a medical response. We make it so different because it's mental health. Those risk factors you see for cardiac disease, you tick them off. Some of them are modifiable, some aren't. Male sex, sedentary lifestyle, you can change. Family history, you can't. There's some things that are modifiable and things that aren't. It's the same in mental health. So those modifiable risk factors are the ones that we're gonna go for, and the genetics are what we get. And many of the illnesses I spoke about are heritable. 40 to 50% are your genetics. So you really wanna know your family history for any kind of disorder and what has happened in your family, even though we don't talk about it. Let's ask the questions. It's amazing what people will share when you ask the direct question. Let's know our histories. We are our history. And then what happens to you once you get here, and there's something called temperament. And you can have 7 people in the same house and have different temperament and different outcomes. So you really have to understand the individual. And when you go out and get help, make sure that you have somebody that is able to understand you as an individual. And you can speak freely about how you feel. The treatment relationship is so vital. You have to have trust. Yes.
Back here, I'm coming.
Hi, thank you for your presentation. My name is Lorena. I, for one, have experienced, my youngest daughter had 2 traumatic brain injury, and she has major depressive disorder. I can tell you how many times she's been in and out of residential treatment, from Newport Beach to Malibu to Beverly Hills. What I did is I petitioned the court so I can get the conservatorship, because she would go for treatment and then if she thinks she's okay, she'll walk out, and that's not how it's supposed to be. Also, try to consider the culture. When I was doing family counseling, and the psychologist told me that my daughter was saying she is having a lot of difficulties. My initial reaction was, what do you mean having a lot of difficulties? Kids nowadays are so entitled. If they want something, they want you to buy it right away. I, for one, was born poor. I have to walk to school, they get chauffeured and drive anywhere. And then the psychologist told me, you do not compare yourself to your child. First of all, you were not raised here, and that's a different generation. So I learned from that.
Oh, excellent. No, I think absolutely, you advocated for your daughter. When she didn't get the care that you need, you conserved her, so that you made sure that she got the care that she needed. And then you educated yourself, absolutely. And there are some cultural nuances. We talked about cultural psychiatry, understanding where we are and what kids are. We didn't have social media. There are a lot of things that we didn't have that are influencing them now. So that educational piece is wonderful. Thank you for sharing that.
Do you guys have another online question? I do. Okay. Any tools and interventions building purpose in the clinical role in session with people who have low-risk passive thoughts? I've heard no harm contracts are now contraindicated. Thank you.
Excellent question. They didn't really mean much. They committed to safety. What does that mean? It didn't mean a lot. So I do a lot of, so I'm a trained therapist. I went to Penn. Aaron Beck was the father of CBT. So anybody who sees me, and Judy Beck was his daughter, my preceptor, they all get CBT in addition to just me talking. So I think that it's important. Repeat the question one more time. I was going somewhere with this. Oh, sorry. Oh, finding purpose. I only connect with people because I'm a spiritual being. So on some level, there are things they don't have to share with me because I glean and I feel and I have gut. So sometimes I try to connect them, if they're willing, to think about why they might be here and how they got here, and to really explore themselves as whole people, physical, emotional, spiritual people. That's the best way to be whole. And sometimes just in sitting in the relationship, that comes out. There's purpose that comes from that. And if people are faith-based, that's often there. But even if they're not faith-based, just connecting to nature, connecting to things that give them life and meaning is very helpful. So beyond just the medication, sometimes it's a medication, it's really helping them find what makes them happy. And we go from there.
Right.
Yes.
Time for one more question. We have one more? If not, we don't have to take one more, and we can turn it back over to Dr. Feldman and as promised, lunch. Thank you.
Thank you, Dr. Walton, for real practical information from a real pro. We are going to take a lunch break, so everyone go get your lunches over there and there. So help yourself, and we'll resume in 1 hour.